What if I told you that, like, 81% of people with vulvas actually cannot reach an orgasm the way society tells them they should?
Wow, 81%. That is, I mean, that's the vast majority.
Right. It's huge. Like, less than 19% can actually climax from penetration alone.
Yeah.
But, if you watch enough movies or read romance novels or just exist in pop culture, you're constantly fed this underlying assumption that experiencing an orgasm is just this universal, effortless reflex.
Like a sneeze, basically.
Exactly, like a sneeze. You get the right physical stimulation and your body just automatically crosses the finish line.
Which is such a damaging myth,
Yeah.
honestly. It creates a tremendous amount of silent distress when your real life doesn't match that cultural script.
Oh, totally.
Because that whole portrayal frames the orgasm as this inevitable biological guarantee.
Yeah.
So if society insists there's like one normal route to this experience and your body doesn't respond to that route,
You think you're broken.
you do. It is incredibly easy to internalize that as a personal failure. You literally start to think, what is wrong with me?
Which brings us to the very real, very complex topic we are digging into for today's deep dive. Because for a really significant portion of the population, that effortless reflex has literally never happened.
Never.
Yeah. And the medical term for never having experienced an orgasm in your entire life is primary anorgasmia.
Right.
And if you walk past a high-end med spa today or just scroll for 5 minutes on wellness social media, you're going to see this highly marketed, super trendy proposed solution.
Oh, it's everywhere. The O-Shot.
The O-Shot, the orgasm shot.
Yeah, and the marketing claims surrounding this procedure are incredibly bold. They frame it as this quick physical fix for a condition that mainstream medicine has historically just, dismissed or totally misunderstood.
So we have a really fascinating stack of sources to guide us today. We are pulling from strict NHS clinical guidelines, some peer-reviewed medical journals, and the actual cosmetic gynecology brochures from places like the Women's Health Clinic.
And we also have real patient support forums.
Yes. Crucially, the forums from Mayo Clinic Connect. So our mission today is to cut through all that aesthetic marketing hype and answer one very $100 injection actually help you orgasm for the very first time.
It's a big question. And to even begin answering whether a syringe can, fix this, we first really need to understand the biological and psychological environment where the orgasm is failing to initiate in the first place.
Right, we have to map out the terrain.
Exactly. Because anorgasmia is absolutely not just a single, uniform condition. The clinical landscape generally divides it into two main categories.
The first being what we just mentioned, which is primary or lifelong anorgasmia, meaning the person has never experienced an orgasm under any circumstances.
Right. Regardless of the type of stimulation, solo or partnered, it's just never happened.
Got it. And the second category.
The second is secondary or acquired anorgasmia. So this describes someone who previously had the ability to climax, but they lost it over time due to some intervening event or medical condition.
And reading through those Mayo Clinic Connect patient forums, it really puts a human face on that secondary loss.
It really does.
There was this one specific thread that stood out from a woman posting under the username Endo234. And she shared this profoundly frustrated story about experiencing early menopause in her 40s after a hysterectomy.
Right. On top of that, she was prescribed estrogen-blocking medications for breast cancer treatment.
Yeah, and practically overnight, she just completely lost her ability to orgasm. Like her body simply stopped responding.
Her story is such a textbook example of how fragile the orgasmic response can actually be. Because orgasms aren't just localized physical events happening in one specific organ,
They're systemic.
Exactly.
Yeah.
They are incredibly complex neurological, vascular, and psychological cascades. So when you look at the root causes of anorgasmia, they are just overwhelmingly diverse.
I mean, in that user's case, we're looking at a sudden, really dramatic shift in hormones.
Right. A shift that literally thins the vaginal tissue and drastically alters the local blood flow. But the physical roadblocks go way beyond just menopause.
Yeah, our sources list conditions like pelvic floor dysfunction, diabetes, multiple sclerosis, which physically interrupt the nerve pathways. But the one that really caught my eye was the prevalence of medication side effects.
Oh, absolutely.
Like selective serotonin reuptake inhibitors, SSRIs, which are like the most common antidepressants on the market. They are notorious for this.
They are, and I think it helps to understand the why behind that. So SSRIs work by increasing serotonin in the brain, right?
Which is great for stabilizing mood.
Right. But higher serotonin levels can actually dampen dopamine and norepinephrine.
Oh, wow.
Yeah, and those are the neurotransmitters responsible for sexual desire and arousal. So the very medication that is keeping a patient's depression at bay is chemically severing the arousal pathway.
That is just a brutal catch-22.
It really is. And similarly, a lot of blood pressure medications work by lowering the force of blood pumping through the body.
Okay, and an orgasm requires intense, localized blood flow to engorge the tissues.
Exactly. If the medication prevents that blood pressure spike from happening, the physical arousal just literally cannot happen.
You're taking pills to keep yourself healthy, and the trade-off is your body's pleasure response just shutting down.
Yeah. But, the sources don't just focus on the physical or chemical roadblocks. The psychological and environmental factors seem equally, if not more powerful when it comes to primary anorgasmia.
And this is where we look at the nervous system as the ultimate gatekeeper, right?
Yes. Deep-seated shame around sexuality from a repressive upbringing or a fear of losing control or past sexual trauma. All of that programs the brain to perceive intense physical sensation as a literal threat.
And when the brain perceives a threat, it doesn't really matter what's happening locally to the body, does it? It just hits the emergency brakes.
That is the autonomic nervous system in action. When
Yeah.
you feel anxious or vulnerable, your sympathetic nervous system, which is the fight or flight response, takes over.
Right.
It floods your body with adrenaline and cortisol. And one of the very first things adrenaline does is constrict your blood vessels to push blood toward your vital organs and large muscle groups.
Preparing you to run or fight.
Exactly.
Right.
So by definition, this pulls blood away from the erogenous zones. It becomes biologically impossible to achieve the physical engorgement necessary for climax because your brain honestly believes you're in danger.
Wow.
The parasympathetic nervous system, which is the rest and digest state that you actually need for arousal, is completely locked out.
Going back to that statistic from Healthline, that less than 19% of people with vulvas climax from penetration alone, it really makes you wonder about the cultural messaging.
How so?
Well, if you're operating with a body that requires entirely different stimulation to reach that parasympathetic rest state, right? But society is handing you a map that only shows one route.
Oh, I see. Yeah, you're inevitably going to get lost.
Exactly.
Yeah.
We are basically giving people a broken map to their own bodies and then diagnosing them with a medical dysfunction when they can't find the destination.
That is such a good analogy. And it maps perfectly onto why the O-Shot is so alluring to people.
Right.
When you're dealing with this incredibly complex, multi-layered problem involving neurobiology and emotional trauma and intricate medication side effects, human nature desperately craves a localized quick fix.
My magic bullet.
A magic bullet.
A magic bullet that happens to cost $1,500, by the way.
Right, yeah, not cheap.
So let's break down exactly what this procedure is mechanically doing. The O-Shot is based on platelet-rich plasma, or PRP. It's been dubbed the vampire fix in the media because it actually relies on your body's own blood.
Yeah, the mechanical process is quite fascinating, just from a purely biological standpoint.
Yep.
So you go into the clinic, and a doctor draws a standard vial of your blood, usually just right from your arm.
Okay, like a normal blood test.
Exactly. And then they place that vial into a specialized centrifuge, which is a machine that spins the blood at incredibly high speeds.
To separate it.
Right. The centrifugal force separates the heavier red blood cells from the lighter plasma.
So they are essentially isolating the, liquid gold of your bloodstream.
Basically, yeah. That isolated plasma is highly concentrated with platelets and growth factors. It's the exact same biological material your body uses to rush to the site of a cut or an injury to begin the healing process.
Okay.
After applying a very strong topical numbing cream to the genital area, the doctor takes this platelet-rich plasma and inject it directly into the vaginal wall and the clitoris.
Okay, so they're extracting the body's natural healing agents and injecting them directly into the erogenous zones.
Yes.
But what are the specific medical claims here? Because the brochures from places like the Women's Health Clinic, they talk about activating pluripotent stem cells. What does that actually mean for the tissue?
Okay, so think of pluripotent stem cells as blank slate cells. They exist in your tissue just waiting for instructions.
Right.
The marketing claims suggest that introducing this massive concentrated dose of growth factors from the PRP wakes up these blank slate cells and gives them a blueprint for regeneration.
Wow.
So the cells are supposedly triggered to generate new collagen, grow brand new blood vessels to permanently increase local blood flow, and even stimulate the growth of new nerve endings in the clitoris.
Okay, I want to use an analogy here to make sure we are visualizing this correctly.
Sure.
If anorgasmia, particularly the kind caused by tissue degradation or menopause, like we talked about, is like a major traffic jam on a crumbling bridge, right?
Hmm.
The med spas are claiming this shot basically restores the structural integrity of that bridge. You inject the PRP and it rebuilds the concrete, widens the lanes by growing new blood vessels, and repairs the warning lights by growing new nerve endings.
That captures their promises perfectly, actually. By rebuilding that bridge, so revitalizing the vaginal and clitoral tissue, they boast that patients will experience increased natural lubrication, tighter tissue, a decrease in urinary incontinence, and ultimately stronger, more frequent orgasms.
It sounds incredible, but our sources wave a massive yellow flag when it comes to the regulatory reality of all this, which we really cannot ignore.
No, we can't. The regulatory environment for the O-Shot is notoriously murky. The centrifuge device used to spin the blood. That is usually FDA approved, but just for general blood separation.
Right, the machine is approved, not the outcome.
Exactly. The O-Shot procedure itself is not FDA approved for treating female sexual dysfunction. Because it relies on blood biologics, it falls into this regulatory gray area where clinics can essentially offer it off-label.
Interesting.
Furthermore, the NHS rarely, if ever, provides it. It is almost exclusively offered in private, out-of-pocket cosmetic settings.
Which brings us to the ultimate collision of these two topics. We know what primary anorgasmia is, and we know the mechanical process of regenerating tissue with platelet-rich plasma.
Right.
So, for the listener who is sitting there having never experienced an orgasm in their entire life, can this $1,500 injection trigger a first orgasm?
Well, if we look directly at the clinical consensus, and specifically at the honest guidance from the Women's Health Clinic source itself, the answer is a definitive no.
No.
No. The O-Shot cannot promise or guarantee a first orgasm.
Look, I have to vigorously push back on that just based on the biology you literally just explained.
I know, it seems counterintuitive.
Yeah. If someone's hand is numb and a doctor gives them a shot that literally grows new nerves and forces new blood vessels to open up in that hand, they are going to feel a feather brushing against it. So if the O-Shot widens the lanes and rebuilds the structural integrity of the bridge, why aren't the cars moving? If the anatomy is completely upgraded to be hypersensitive, why wouldn't that guarantee a physical climax?
Because you are assuming the problem is the structure of the bridge.
Oh.
Yeah. A first orgasm, primary anorgasmia, is almost never a structural issue. It is a software issue.
A software issue.
Yes. The female orgasmic response requires the brain, the software, to feel safe enough to release control and allow the parasympathetic nervous system to actually take over.
Right, the rest and digest.
Exactly. Let's say a patient has deep-seated anxiety or a trauma history, or they suffer from vaginismus, which is a condition where the pelvic floor muscles involuntarily spasm and lock up out of sheer fear.
So in that scenario, the physical hardware might be perfectly healthy, but the brain is sending a signal that just says, do not proceed.
Exactly. You could have the widest, most structurally sound bridge in the entire world, with millions of brand new nerve endings acting as sensors. But if the software is stuck in a fight-or-flight traffic jam, no amount of new blood flow to the clitoris is going to override the brain's inhibition. The new nerves will just send sensory signals that hit a brick wall in the brain. You cannot inject trust, relaxation, or nervous system regulation with a syringe.
That makes total sense. And it explains why the O-Shot is highly effective for someone like and Jen 234 from the Mayo Clinic Forum.
Yes.
She had secondary anorgasmia caused by physical tissue thinning from menopause. For her, the bridge actually was crumbling.
Exactly. Rebuilding the concrete with PRP removes the physical pain that was blocking her climax. If it hurts to touch, you obviously can't relax.
Right. But if you've never had an orgasm, your bridge is likely completely fine. You're just stuck in the software traffic jam.
That is the crucial distinction. The O-Shot is a hardware intervention. It is fantastic for tissue degradation, vaginal atrophy, or painful skin conditions like lichen sclerosis.
Yeah.
But for primary anorgasmia, throwing a hardware upgrade at a software problem will just leave you $1,500 poorer and just as frustrated.
Okay, so if the magic needle isn't the starter button for a lifelong inability to orgasm, what do our sources actually recommend for someone trying to climax for the very first time?
Well, the clinical guidelines from both Lloyd's Pharmacy and Healthline recommend a holistic approach, one that simultaneously addresses the hardware and the software, without jumping to experimental cosmetic procedures.
Makes sense. Where do you even start?
The very first step is tackling the medical basics. Sit down with a doctor and comprehensively review every single medication you take. especially those SSRIs or hormonal birth controls, to see if they are chemically blunting your arousal pathway.
And assuming the medications are cleared, the sources point really heavily toward physical and psychological therapies.
They do.
For instance, seeking out a pelvic floor physical therapist. I think most people think of pelvic floor therapy just for, like, incontinence after childbirth.
Oh, yeah, that's a huge misconception.
Right. But if your muscles are hypertonic, meaning they are chronically clenched way too tight, they literally spasm and restrict the necessary blood flow, making pleasure basically impossible.
Exactly. A therapist can physically map those trigger points and teach you how to release them.
And parallel to that physical release is the psychological release.
Mm. A trauma-informed psychosexual therapist is absolutely vital for unlocking the mental conflicts, the shame, or the performance anxiety that keeps the sympathetic nervous system locked in fight or flight. You have to actively teach the brain that pleasure is safe.
But beyond the clinical appointments, I actually found the practical, at-home steps from the sources to be the most empowering.
Oh, for sure.
Like, the Lloyd's Pharmacy guidelines specifically suggest going completely back to basics with anatomical exploration. They advise taking a hand mirror in a private, comfortable setting and physically getting to know your own genitals.
It sounds incredibly simple, right? But a massive barrier to a first orgasm is simply not knowing where or how you like to be touched, because society has actively discouraged you from looking.
It goes right back to your broken map analogy.
Exactly. You cannot expect a partner to find the destination if you haven't mapped your own terrain first.
And part of mapping that terrain is understanding the tools at your disposal. The Healthline source gets very specific about vibrators. They advise against using buzzy, high-pitched vibrators and instead recommend using a rumbly vibrator like a wand. I was actually curious why the frequency of the vibration actually matters for achieving a first orgasm.
It matters entirely because of the anatomy of the clitoris, which is far, far more complex than most people realize.
Yeah.
What is visible on the outside, the glands, is literally just the very tip of the iceberg.
Right.
The clitoral structure is actually quite large, with crura, or legs, that extend deeply internal, wrapping all the way around the vaginal canal.
Oh, wow.
Yeah. So a deep, heavy, rumbly vibration penetrates through the external tissue to stimulate that entire unseen internal structure. A superficial, high-pitched buzz often just overstimulates and irritates the external nerves without engaging the deeper anatomy at all.
Engaging the whole system is key, which is also why the sources recommend Kegel exercises for pleasure, not just for bladder control. Practicing tightening and relaxing the pubococcygeus muscles, the ones you use to stop the flow of urine, forces you to build a stronger mind-body connection to your pelvis.
It does.
It literally trains you to increase blood flow to the area on command and helps you recognize the physical sensations building up rather than panicking when you feel them.
It brings intention back to the pelvic floor.
Mm.
And that intention has to extend to partnered sex as well. The sources are incredibly blunt about communication.
Oh, yeah. The consensus is crystal clear. Stop faking it.
So faking it.
If you have been faking orgasms with a partner to get sex over with or to protect their ego, you are actively sabotaging your chances of ever actually having one.
Because faking it gives your partner completely false feedback. You are literally training them to do the wrong thing.
Exactly. How will they ever learn what actually brings you pleasure if you are cheering them on when they are doing something that feels like absolutely nothing to you?
It just reinforces the broken map. The advice is to shift entirely to positive reinforcement. So instead of criticizing what they're doing wrong, explicitly guide them in real time by saying, you know, I really like it when you touch me exactly this way.
It removes the guesswork.
Completely. And it builds the trust required to pull the brain out of that fight or flight state.
Looking at all these holistic steps from the sources, the hand mirror, the rumbly vibrator, the pelvic floor mapping, the brutally honest communication, it strikes me that these steps are fundamentally about reclaiming ownership of your own body.
Absolutely.
You are actively doing the work to understand your own neurobiology rather than outsourcing the responsibility to a cosmetic med spa procedure.
That is the core takeaway. The O-Shot outsources the solution to a syringe. The holistic approach requires you to become an active, curious participant in your own sexual wellness.
So, to synthesize everything we've pulled from the stack today, the O-Shot is undoubtedly a fascinating piece of regenerative medicine.
Oh, for sure.
If you are dealing with tissue degradation, vaginal atrophy from menopause, or urinary incontinence, the platelet-rich plasma science demonstrates real, tangible benefits. It can absolutely upgrade the hardware and rebuild the bridge.
Yes, it can.
But when it comes to experiencing your very first orgasm, human sexuality is far too complex and far too dependent on the nervous system's software for a one-size-fits-all needle.
It is a multifactorial puzzle. You have to investigate the medications, calm the mind, release the hypertonic muscles, and really understand your own internal anatomy.
And I want to leave you with one final, deeply provocative thought pulled from the source material that really challenged my own perspective on this.
All right, Kate, let's hear it.
We had spent this entire deep dive talking about the effort required to reach that first orgasm, right? The therapy, the anatomical mapping, the communication. But what if the effort itself is the problem?
Oh, the paradox of trying too hard.
Exactly. The sources point out that pressure is the ultimate orgasm block. The internal monologue of, is it going to happen this time? Am I taking too long? What is my partner thinking?
Yeah, that anxiety instantly triggers the sympathetic nervous system we talked about earlier.
Right. It spikes the adrenaline, constricts the blood flow, and actively kills the arousal. So what if the secret to achieving your first orgasm is to completely intentionally stop trying to have one?
By removing the goal, you remove the anxiety, which allows the parasympathetic nervous system to finally take over.
If you redefine intimacy so that an orgasm isn't the grand finale or like the mandatory finish line to prove the sex was successful, but rather just one of many possible optional side effects of feeling pleasure.
Wow. Yeah.
How might taking that immense pressure off be the exact key that finally unlocks the door? If we stop treating it like a reflex we have to force out, maybe the software can finally relax enough to just experience it.
That is incredibly powerful.
Something for you to think about. That is our deep dive for today. Keep exploring, keep questioning, and we'll catch you next time.